This video, and later discussion with Dr Vilas Navapurkar, is part of the MAXVAC series of educational talks about the importance of clean air. Dr Navapurkar and his colleagues at Cambridge University Hospitals have published a method of accurately identifying and measuring the disease-causing microbes in the air we breathe. He and his team used their method during the COVID-19 pandemic to demonstrate that sufficient air filtration removes SARS-CoV-2 and other potentially harmful microbes from the air we all breathe in. For MAXVAC, this is compelling and robust evidence that just like the use of FFP3 masks, breathing in fewer microbes will contribute to a decrease in airborne disease transmission. Therefore, deploying air filtration units and measuring their effect to optimise their impact should be the way forward for effective infection control, in not only hospitals, but in numerous other settings, from schools to the workplace. It's a simple message. Cleaner air leads to a healthier environment. I hand you over to Dr Navapurkar.
My name is Vilas Navapurkar and I'm a consultant in intensive care medicine in Addenbrookes Hospital in Cambridge University Hospitals. And I'd like to share with you some thoughts of mine and perspectives around some of the work that we've done in ICU and in Addenbrookes around cleaner air, its importance, significance and methodologies. Just for a question of probity and transparency, I'd like to declare that these are opinions of mine and not those of CUH, Cambridge University Hospitals, or the University of Cambridge, and that I am agnostic of manufacturers' products of air filtration units. I know very little about them. And I've not been paid for this educational discussion, as it's a part of my territory to share and infuse my experiences and knowledge into the public domain for debate. And finally, just to share that I've registered a company, an inactive company at the moment called Cambridge Infection Diagnostics. So this is where I work, which is Addenbrookes Hospital in Cambridge, and this is the intensive care unit that I work on, which is the John Farman Intensive Care Unit, where I've been an NHS consultant for the past 26 years. And I'd like to emphasise that I'm not a member of the university. I'm a purely and simple jobbing bedside clinician, and I've been there for so long making the decisions that influence and manage patient care of the critically ill. And as you all know, we've been through some terrible times of late with the worldwide pandemic, the COVID-19 pandemic. And during that time period and since then, we've learnt a lot, and we've learnt a lot about some of the things that we can do to decrease the impact and the incidence of airborne disease. And so I was going to walk through or share with you a summary of what I think could be done better and what are the reasons for doing this. So I was going to talk about my 4 I's for cleaner air. So why do we need cleaner air? The indications. What do we do about cleaner air? The interventions, air filtration. And what is the impact? What is the potential impact of both clinical and non-clinical of the identification and quantification of what bugs are in the air or pathogens? And what are those implications? What are the implications if we remove or decrease the number of infection-causing organisms, microbes in the air? So that's a summary of what I wanted to share with you and talk through, because one of the biggest problems that we have across the world, not just in the UK, across the world in intensive care and also on the hospital wards, is pneumonia. It's a common infection, especially in those patients on ICU who either come to us with infections, as they did during the COVID pandemic, or are there for other reasons and develop infections. And that's really, really important. And pneumonia is a very nasty, nasty condition which can be caused by all sorts of things. Bacteria, for example, the pneumococcus here in front of you. This is a very common bacterium that causes infection and pneumonias. And what it does and what infections do and what pneumonias do is they damage your lung architecture. Here's an example of a healthy chest x-ray. And as you can see, the edges or most of the lung fields here on the left and on the right are dark. These dark areas are healthy air spaces. There's air there, nothing else, which is why it's not picked up on an x-ray plate. And you see a similar thing with a CT scan here. You can see the right lung here and the left lung here, and these are nice dark smooth areas of lung field. However, if you get an infection, things change. And things can progress very severely to this end of the spectrum, where you can see there's very little dark tissue left in the lungs. And those lung fields and those little bags are all filled up with fluid, protein-rich fluid, pus, bacteria, sometimes and a lot of hemorrhage as well, blood. And these lungs then get filled up and become very, very, very consolidated. As you can see with this CT scan, it looks very, very white here. And these kind of lungs is very difficult to get air in and out of. And this is really important. And here's another example. As you can see, the lung fields being filled up with pus and fluid and hemorrhage. And this means that the lungs are not working. You can't get oxygen in, you can't get carbon dioxide out, which is why you end up on breathing machines, which you can see some of the equipment that we use to prevent death here in this particular patient. And this is towards the end of this pneumonia process, whereby you get so sick that people like me and my colleagues in intensive care are involved. And these patients have a high risk of death, something like a 20% chance of survival, 80% risk of death. And survival is not always good because the lung architecture is so badly damaged that the rest of their existence is one of suffering. But even before you get to intensive care, there's a huge journey of suffering to go when you get a pneumonia of this severity. And people can die on the wards or die with us, but the route to death involves a lot of suffering. Shortness of breath, chest pain, panic, fear, tiredness, exhaustion, plus all the other signs that we see as clinicians, such as temperature and blood tests going wrong. So it's a really horrific situation to find yourselves in, and unfortunately, we've seen a lot of it. Over the past few years, the conversation in intensive care has been about mass mortality rather than suffering. And we've seen a lot of death from this COVID pandemic. And here you can see the COVID viruses within the alveolar sacs, here within the lung fields here, that trigger a response. Now, this is very important because it's not the virus or the bacterium or the fungus even that actually kills you. It's your response, your inflammatory response to these invading pathogens, as we call them. And it triggers a host response. And that host response results in a lot of local damage within the lungs, which then has a knock-on effect on other body systems, blood pressure, brain, urine output, and you can go into multi-organ failure, or you can stay with severe respiratory failure. And we saw an awful lot of multi-organ failure in the pandemic. So it's really important to understand that it's not just the bug, but it's how an individual responds to the bug. And one thing that all human beings have in common is that we're all different. And there is a variation in response, and therefore you could flip it around, and what people often talk about is a variation in vulnerability to disease and to infection. And some people are far more vulnerable. And certainly in the pandemic, we saw that in patients who are morbidly obese. They had a much higher incidence of severe pneumonia and death, as did those patients who came out to us from areas of high deprivation. So it's very important to understand that many patients, even with COVID and with other things as well, can be asymptomatic, i.e. not develop symptoms and signs, or, as is very often the case in COVID-19, they can be pre-symptomatic. So there's a time lag between acquiring the infection and then the body responding to it sufficiently to make you unwell. And during that pre-symptomatic phase, there's a lot more spread because you are interacting more and there's a greater risk of airborne transmission of disease. But again, so to summarize these two sequences of slides, health is health with clear lung fields. You get an infection that penetrates to the depths of the lungs, and those are small particles that take things into the depths of the lungs. You can set up a response, and that response varies between people. And the response can be sufficiently severe to cause a pneumonia, which has grades that can result in multi-organ failure and death, or can be less severe. But all of those grades, all of them, entail a huge amount of suffering for an individual. And here again you see in an X-ray, the classical changes of COVID that we got used to during the pandemic. In fact, you see it when your eyes are closed. These kind of patches that you see of consolidation or whiteness, which in areas that should be black, they're diffuse and pretty characteristic. And the end result of all of these patients is you end up on ventilators and doing the things that I do every day, which is trying to prevent death and reverse organ injury and try and restore some organ function and get people off these breathing machines with as limited damage to their lungs as possible and other organs, and hopefully get them to survive and out of ICU. And it's common. These data are before the pandemic, 2018 to 2019. And you would say that to intensive care alone, we're getting about 41,000 patients admitted with respiratory illnesses, usually an infection, usually a pneumonia, usually bacterial, but often viral, and sometimes fungal. And that's pre-pandemic. And since the pandemic, there's a heightened awareness, there's a heightened anxiety, and we're seeing more and we're looking for it more. So it's a lot of patients, and that's a lot of suffering. And the key thing to understand is what's in the air, and does it matter? Well, it does. And knowing what's in the air that you're breathing in is important, because within that air can be very small particles called bioaerosols, in which you have viable pathogens or microbes which can be inhaled and reach the depths of your lungs. The bigger particles, more than 15 micrometers in diameter, tend to get filtered out in the upper airways, but the smaller ones, 1 to 15 or 1 to 10 micrometers, travel all the way through and can enter into the distal parts of the lungs and set up the inflammatory processes that we shared with you in the X-rays earlier on. So it's really important to know what bacteria are in the air, what fungi are in the air, and what viruses are in the air. And this will vary. It will vary a lot. And lots of infection is caused by airborne transmission of disease. And if you're in a concourse, say in a hospital where everyone's walking in and out, chances are that you won't have a huge burden of bacteria, viruses or fungi that can cause disease. However, if you're in one of the transplant wards, or in a care home, or in a care of the elderly ward, or in an orthopedic ward, where there's limited mobility, limited health, you're much more likely to get a different bacterial or viral and fungal burden of bioaerosol. And if you think about elderly people, as we age, our joints stiffen, our muscles weaken, and so our breathing diminishes, and our ability to breathe diminishes. And so in care homes and in elderly wards, or even people with sick, the chest almost acts as an incubator for pathogens. And so when someone coughs, they'll be coughing out a bigger load of pathogens than in health. And also when people speak, they will be dispersing a lot more pathogen or microbes than when they cough or splutter, because the coughing and spluttering produces bigger showers of bigger, heavier particles that then tend to drop to form fomites, which are a source of infection from surface contamination. But the smaller ones, which can reside in these damaged lungs or elderly lungs, they tend to come out when you're speaking. And that's really important. Phonation is a bigger producer of bioaerosols with pathogens or microbes in it than coughing or spluttering, because that produces the smaller ones that reach the depths of the lung. And if you're sick and you get a pneumonia, then those elderly mechanics or those abnormal mechanics are changed even further. And so you produce a bigger burden into the air. And everybody's different. And we saw a lot of this in the pandemic, especially in wave 2, that some patients were super evolvers. And we have the ability to measure the amount of virus SARS-CoV-2 in the depths of the lung in Addenbrookes. And we found that there were some patients who had a ridiculous amount of pathogen, multiplying for ages, for days and days and days and days and days. And these patients are usually immunocompromised anyway. But the point about that is if you've got such massive multiplication over such a massive amount of time, you're going to get a greater mutation rate. And these are the patients not only will become super evolvers if they come off breathing machines or ventilators, and if they get back to the wards, they could even be super spreaders. And there are many people who are super spreaders that are asymptomatic or pre-symptomatic. So the thing is, it's not just the air that you breathe, but who's breathing it and what's their risk. And that's what you need to know. And it's not just COVID, because this slide is very clearly shows there's a small example of the number of common diseases that we see that are known to be of airborne, transmitted by airborne transmission. So that's very important. And so here's a summary of what the problem is. And the problem is this bit here in these smaller particles. The bigger particles, which tend to form fomites and do cause infection, you can try and mitigate risk by surface wiping and sensible hygiene. But to add to this mitigation of risk, we know that you can prevent airborne transmission of disease by wearing FFP3 masks. So quite clearly, if you remove the bugs from the air that you're breathing in, your risk decreases. And you can do that by wearing a mask or by having cleaner air. And the question is, how do you know it's cleaner air? So this is a really important slide here. This is the anatomy of the SARS-CoV-2 bioaerosol. And it's pretty emblematic of the way of bioaerosols for other kinds of microbes or pathogens, microbes that cause disease. And it involves a fluid a capsule, and it has certain proteins in it, and it has ionic charge across the membrane, and it floats around in the air. And we know that SARS-CoV-2 hangs around in the air for about 3.5 hours with a half-life of about 1.1 hours. And this is very important because it's very small. And this is 1 to 15 micrometer particles of bioaerosols that are inhaled into the depths of a patient's lung or a human's lung and set up the inflammatory response. And it's important to know a bioaerosol is very different to carbon dioxide. Carbon dioxide is not an infective agent, and it's very different to other pollutants like silicone and lead and other things that are of importance, but are very different to infection risk. So bioaerosols are the key, and their measurement, knowing which bioaerosols and showing that they've gone from the air, is important. And we know that airborne transmission of disease exists. There's a wealth of evidence, mountains of evidence for it. And here's a paper that summarizes it all, and you can see here's the DOI for it at the bottom here, which you're all welcome to read. It's a good little summary of the evidence basis for airborne transmission of SARS-CoV-2. And it points out that one of the problems has always been, how do you prove what's in the air? Because capturing those particles, let alone telling you what's in those bioaerosols, is very, very challenging, and has been for science and medicine for many, many years, because the methodology for capturing them results in damage to the RNA or the DNA of the virus or pathogens, can result in accumulation, can result in a re-aerosolization, and there are many sources of error as well. So it's very difficult to actually capture those air particles that you breathe that go into the depths of the lung, the small particles, and it's even harder to tell you what's in there and to measure how much is in there. So the next two slides really delineate why it's the evidence basis for airborne transmission of disease. And this summary in the Lancet is a really good summary of 10 major reasons why we know that SARS-CoV-2 or COVID-19 was airborne in its transmission. And I recommend it as a good read. And one of the key things about it is the wealth of evidence from tests that show transmission across distances and across by phonating rather than coughing, and also that there are a lot of patients who are asymptomatic and pre-symptomatic, and we found that as well in Addenbrookes. And you can see here in the red square here when we did asymptomatic testing of the healthcare workers or staff, that a lot of patients were in fact positive for it. Again, it's in 2020 at the beginning of the pandemic. And the next slide here on the right shows that what do, what happens to the acquisition of COVID-19 if you change to FFP3 masks, which filter out those small 1 to 5 micrometer bioaerosols. And you can see here in the blue area that once you get to FFP3 masks are used, there's a significant drop in acquisition of COVID-19. So that's very important. We know it's airborne disease, and we know it's there, and we know there are many other diseases that are airborne in their transmission. So prior to the pandemic, myself and my colleagues in the ICU and in the Baker Lab in the University of Cambridge have been working on some rapid diagnostic methodology, and we'd validated a method for doing microfluidic nano-PCR. And this is using this equipment here on the left, where you can see my colleague Leanne working with it, and it's called the Fluidon Biomark system. And we'd validated it, and it's a microfluidic circuit that works on really, really tiny PCR interactions or reactions. And we knew it worked. And so I wondered about whether we could use our capability here in the up and coming pandemic, which we knew was coming to us in January, February 2021. And the problem was how to capture the bioaerosols. So I was fortunate enough to have a cup of coffee with one of my colleagues who kindly lent me some anthrax samplers. And he lent me a few, and we dispersed them around the ICU and on the wards and closed areas, and we measured the bioaerosol burden using this Fluidime capability of the particles that were captured, or the bioaerosols were captured, and those were very tiny. They were 1 to 10 micrometers. And here you can see we showed a significant decrease in the pathogens of not just SARS-CoV-2, but other pathogens when we tested in the presence of air filtration units. And this is another example where you can see 3 squares here. That's week 1. Week 2 and week 3. And in week 1, we tested the air, captured it with those anthrax samplers, and used the Fluidime biomark methodology that we'd validated to quantify and qualify, i.e. tell us what's there and how much of it is there in those tiny bioaerosols. And we did it first in week 1 with the air filtrations present but switched off air filtration units. And then in week 2, they were present and switched on. And in week 3, we switched them off again. As I can see, SARS-CoV-2 was absent in the week when the air filtrations were switched on. And to our knowledge, we're the first group to have shown this. And the reason why I thought it would be useful to do this is to see whether we could adapt our technology to show whether there was any microbial scientific evidence that underlay the use of these air filtration units, because I was unable to find any prior to our work, including having done a wide literature search. And interestingly enough, because we had the capability, we looked for all sorts of other pathogens as well. And you can see here in week 1 that there are many other pathogens in the air, both fungi and viruses, not just COVID, fungi and viruses, other types of viruses and bacteria, and they all went when we switched the air filtration on. There's virtually nothing. And that's an important methodology, because we were the first group to be able to show we could capture those tiny particles in the air, tell you which bugs are in there, and quantify them. And therefore we now have a methodology for measuring, as I call it, the microbial bioburden. But what I mean by that is how many bugs are there and have they gone? And that, to our knowledge, has not been demonstrated before. So we published a paper. That paper has been widely reported and quoted and cited, and there's been a fair bit of interest generated from it. And that's all very good, but where does it lead us is the question. And as I said, I'm a clinician, I'm a bedside clinician, and my concern is to see how and whether I can protect people from acquiring infection. And as we discussed earlier on, it's not just the pathogen that's in the air, or the microbe, that's in the air, but it's who's using those air spaces. Are there patients that are more vulnerable? Are they on steroids? Have they had transplants? Are they elderly? Do they smoke? Have they got asthma? Have they got COPD? There are high-risk groups for infections? Are there children with bad asthma? So there are high-risk groups. So it's really important for me to know, and my colleagues to know, not only what's in the air, but who's breathing that air, because the risks will vary. And that's the key thing that I wanted to share with everyone, that we now have the ability to risk profile a room. And by that, I mean we have the ability to now say what's in the air, link what's in the air to the risk of cohorts of people within those rooms, who's using the room. And every room is different. The activity is different, the people are different, and the number and types of bacteria, I guess, will be different. And even in similar groups, for example, plucking it out of the air, 2 separate care homes, it would be interesting to know whether one has a greater bioburden than the other. Because if we did know that, we could improve the care and bring up standards across a range of care homes. So that's the key message that I want to go. We now have an ability to risk profile a room by saying what's in the air and linking that to the vulnerability of the patient groups that are in there. And that's not been done before. And you need to know whether your solutions are working, because air filtration is a sensible way forward economically and strategically, and it's also very flexible. And so to know whether your solutions are working is really important. What would be wrong would be to wheel in machines and assume things are working without testing them. And I think that's a mistake. And I wonder whether in time people will think that we have standards for cleanliness for food and water. Well, we now have the ability to learn what is a standard for air and how to meet that standard and monitor it. That's a really important summary point to get to, is what is the problem? Well, the problem is airborne transmission of infection. Can we mitigate this? Well, yes, we can. We can deploy air filtration units if we know that they're working. So how do you know you're mitigating risk? Well, you'd have to measure the bioaerosol burden and show that it's gone or reduced. And key is to risk profile places, because some places are much higher risk than others. So you would want to, or I would want to, go into transplant wards, cancer wards, elderly wards, and care homes, and also schools. Schools are really important because they're reservoirs. Although the patients or the people, the children may be well and active, they are reservoirs for disease dispersal, especially when they go home and have elderly parents and stuff. So this is really important, in my view, a contribution towards mitigation of risk of airborne transmission in conjunction with other things. You can't just scrub the air and not wash your hands after loo, or not flush the toilet, or not be careful how you cough and splutter. So I think this is a way forward, a new way forward, of mitigating risk. And the pandemic has got endemic consequences. It's not going to go away. And even if I'm pretty convinced that we will see other pandemics coming along. But if not, there's heightened anxiety about the pandemic and its consequences and effects. Because you only need, on my intensive care unit, you only need 1 or 2 COVID patients, and you have to cohort the whole area, which wipes out a whole bulk of nurses and doctors and resource. And we're not resource rich at the moment. And there's also an increased awareness of risk, people wearing PPE, etc. But we could enhance the efficacy of that PPE by removing the bacterial or the microbial bioburden in the air. And my colleagues there's an increased diagnostic anxiety. We look for pathogens more, and we look for viruses and fungi and bacteria more often, because we've just been through this and we have the ability to do so. And the other thing is that even amongst the public now, there's a great awareness, stroke anxiety about seasonal surges, influenza, RSV. We're seeing a lot of RSV. And the viruses are very, very unstable. And because they're so unstable, the RNA is so unstable, they mutate so much. And you will get confluence of viruses and merging of viruses and stuff. So we're aware of it, we look for it more, we'll see it more. And so it's very, very important for us as clinicians to recognise that. But if we can mitigate the risk using a constellation of factors, of which this is a new start point, I would hope, if it was scaled up enough, I would hope that we'd be able to decrease the number of admissions to hospital or even to ICU, reduce the demand of GPs, decrease the need to patrol hospitals and care homes, and also provide a positive standards for which a range of care homes or institutions or schools or hospitals can all meet, just as we have for food and water. It would be interesting and useful, I think, to mitigate risk of airborne transmission of disease by having a standard of air cleanliness, which we can now deliver. So in summary, what I'd like to message, or the message that I would like to get across really, is our ability to capture those tiny bioaerosols that cause airborne transmission of disease is new. It's effective, it's worked, it's peer-reviewed and published. And we believe, and I believe, and my colleagues in my group believe, that we've got a new solution that will strengthen current capabilities of what we have on the wards and in care homes and in other areas. And that strengthening of current capabilities will decrease the risk of airborne transmission of disease, as well as increasing the efficacy or the effectiveness of the current levels of PPE, which we will need again, I'm sure. So in my opinion, a new way of approaching solutions that are impactful at the bedside across a range of populations, a range of people, is important. And we won't get that unless you involve and work with bedside clinicians who are experienced in knowing what the problems are, what the potential solutions are, and can provide with real-time information of efficacy and accuracy and deliverability. And that's the thing for clinicians, that we want to know, or I want to know, what can I do with it? Even though the science may be fancy, it still boils down to me as a bedside clinician at 3 o'clock in the morning saying, what do I do with it? How do I use it? How's it going to help my patient? And then I'll move on to the next problem. So immersing ourselves in complex scenarios that have complex target points is not going to be effective across the scale that we do. Whereas some things like this can go forward if we have new ways of approach, which involve clinicians, science, industry, business and charities. And on that note, I'd like to bring this presentation to an end and congratulate my colleagues and friends in the air filtration industry, because you've obviously moved a long way from this slide, which is at the Second World War, for bicycle-powered air filtration units, which will never get into an ICU, I can assure you. And thank you very much for your kind attention.
Why did you start your research at Addenbrookes?
The COVID pandemic was really severe in wave 1 starting in February 2020. And I worked throughout all of that. And one of the things that we had to do was to isolate patients until we got so many that there was no point in isolating.
Why is this important?
So some of the other research preceding the pandemic was on the rapid diagnostics and pneumonia. And I and my colleagues had established a service in Addenbrookes for rapid diagnostics of what's the bug in the lungs that's causing a pneumonia when you're in intensive care on a ventilator. And the severity of the pandemic really stretched us both physically, psychologically and resource-wise. And patients were getting all sorts of secondary infections as well as COVID-19. And at the time I remember thinking what we need to do is to develop some kind of hot chest ICU where our diagnostic capability would be allied to isolating within a room. And I looked into that and I thought, not possible, not in the scale that's required, the timing that's required. So it wasn't possible. And so I was still scratching my head as to how I could protect staff and patients on our ICU. And I came across some air filtration units that weren't being used because we weren't doing anything except COVID at the time. And I looked at them and I thought, oh, they might be helpful. Do they work? Which is the obvious question, and I couldn't find any evidence that they did. So I had a good old literature search, went through all the SAGE documentation, and there was no evidence that I could find that anyone had shown that they removed microbes that cause illness. There was speculation, there was a lot of work done on inorganic particles, smoke, dust, in laboratories or in machine rooms, but nothing in the real world or in the real wards. So I wondered whether we could do anything using my new validated nano PCR capability with myself and Andy Conway-Morris and Stephen Baker, as to whether we could use that highly sensitive nano PCR to identify what's in the air, if only I could capture the air. And then had a chat with one of my colleagues who turns out who had some anthrax samplers on loan from the CDC in Atlanta. So for the price of a coffee, he lent me some. And so he lent me some, and I thought, let's see whether this works. And these were samplers that we then distributed on the wards and in ICU during the height of the pandemic, because I knew by the autumn of 2020, as did all of my colleagues, that another wave was going to come. We hadn't quite expected the ferocity of wave 2 in sheer numbers and suffering. But I thought, why don't we see in wave 2 whether these machines work? Why don't we see whether we can prove we can capture the air, the bugs therein, and show that they're gone? Because that could form a baseline of a protective strategy. I must confess my colleagues thought I'd gone mental and they didn't think it would work. But we did, and we used those machines, those air samplers, in the height of wave 2 in February 2021, both on the COVID wards where they're not ventilated, on the COVID wards in intensive care. And it's as in the paper, we thought, wow, it does work. And our capability is such that we could capture the air and measure the bugs. And this was the first scientific proof, as is evidenced by lots of attention in the media and in the press and in the medical literature, that of an ability to capture the air and prove their efficacy. So that was why I did it. The intent was to see whether there was any mechanism that would diminish the risk for staff and patients, both in ICU and on the wards, and we were right. It did work.
And did it surprise you that it wasn't just COVID that
No,
was caught?
no, not at all. I remember through the COVID thinking, there are so many other ways to die. COVID isn't the only one. However, because we had the ability in the Baker lab to measure whatever pathogen we want, whichever way we want, I thought, let's look for everything. So no, it didn't surprise me because the mechanism is the same. There are unique features about COVID-19, many unique features about COVID-19, but it is a pneumonia. And there are lots of causes for pneumonia, and there's lots of airborne transmission. So I was not at all surprised that we found other bugs at all. What I was surprised at was that we could capture the air and measure it, so I was pleased.
Has COVID changed the way that you look at transmission?
I think I believe that this, and I'm sure my colleagues in my group also concur, I think that this is important as a risk mitigation for airborne transmission of disease in those areas with high vulnerability. It could be applied to areas that have got lower vulnerability, but I don't know. But I'm sure that in places like businesses and offices and like, there will be people that are on steroids, who have had transplants, or do smoke, who have got COPD. There will be changing variations in vulnerability. But my primary concern at the moment is care homes and hospital wards. And the care homes in wave 1 and 2 and 3 were main drivers of our acquisition of patients with COVID-19. And also, you know, we've known, for example, tuberculosis for decades and decades, centuries even, is airborne transmitted disease. So no, I wasn't surprised that we found other pathogens and other bigger pathogens such as fungi and bacteria. And one of the key things that I was interested in was how dirty the air actually is in those areas that have a high activity of patient activity and staff activity. And it's leading me to think that that activity will vary per unit time. you only need one cardiac arrest on the ward, and I'm guessing and I'm sure that you'll get a huge difference in the microbial bioburden when that happens, when people are rushing in and out, or when you change a bed sheet. That will disperse lots of bioaerosols. So I'm increasingly beginning to think that it's a dynamic area in which there will be predictable and unpredictable changes, but there'll always be a risk unless you remove it. And the more I've been thinking about it a lot. The two approaches, we could either try and drill down to see what's there, and we can do that anyway, and try and compare what's there in different areas and risk profile like that. Or we could do what I want to do, which is remove everything as much as you can. And because the other interesting thing that will have is that it will buffer human behaviour. I do remember in 2020, I think we all remember 2020 or 2021, there was a lot of antagonism towards wearing masks and things that were important for social awareness of risk. And there's a lot of variation in activity, and you can't do anything but accept that. But you could buffer that risk if in areas you were to decrease the microbial bioburden of whatever they do. So even if they chose not to do things that are recommended, you'd still protect them. So I think it's a whole new domain of thought around how we can add to risk mitigation of disease progression and severity. Because you don't know who's in the room, you don't necessarily need a lot. Because some people can hyper-respond, for example, immunocompromised patients, as we saw during the pandemic. And a lot of the patients with COVID pneumonia died with secondary pneumonias, not because of the COVID, because of other things that they got, or infections that on central lines and things like that. So there are many ways to suffer and to die. So it opens up a whole new realm of thought.
When you look at the machines and other ways of mitigating it, why don't you just open up a window?
Opening a window increases your ventilation. It's very unpredictable, opening a window. You can let pathogens in as well as out. And you have no way to say that I doubt if there's any mechanism by no matter how many windows you'd open that you'd ever achieve enough room volume filtrations per hour to diminish the microbial burden in that air. We showed that we could do it with 5 to 10 room volume filtrations per hour. That's very unlikely by opening a window. What you'll do by opening a window is improve the amount of air in there, decrease the amount of carbon dioxide, but not necessarily know that you're decreasing the infection risk. It's not a titrated response. And I think if we want to do this scientifically and appropriately and correctly, you've got to make an intervention, know what the intervention is, and measure the response. And if you open a window, you don't know what the intervention is. It's just opening. How big's the window? What's the air like outside? Are you next to a motorway, or are you next to another school? Or, I don't know, too many confounding variables, too many. Whereas I think if you have a room volume filtration per hour target and you measure the burden, microbial bioburden as I keep calling it, but I mean the number of bugs in the air, in those small particles that get to the depths of the lung, you will then be able to protect throughout the year and not just through the summer. You can't open the windows all the time. The heating costs are huge. So there is that economic argument. But I suppose from the infection risk, it's unpredictable.
Could machines remove mould? Is mould an important factor?
By mould, you mean fungus, and yes.
Yeah.
Yes, we've measured it. We measured Aspergillus in the air. We found it, and we showed that it went. So yeah, and we see, unfortunately, in our haematology oncology patients, our blood cancer patients, a lot of fungal infections. In our transplant patients, a lot of fungal infections. And this is really a really important point, because for whatever reason, a lot of our institutions are old and have an infrastructure that lends itself to accumulation of pathogens in air ducts and pipes and surroundings and taps, water taps. And so that risk is always there. And some people are living longer, and they're living pretty well managed longer. So when they do get sick, they get sick with a whole load of diseases. And so the susceptibility to non-bacterial and non-viral infections is also higher. So yeah, I think viruses, bacteria and fungi, as we discussed in one of the slides, they're all at risk. And the question, I suppose, boils down to whether we try and identify and measure everything, or we just get rid of everything and see what's left. And that's my preferred option, because I think it's about protection of humans, of patients. And you can't say, you don't know who's going to be hyper responsive to a certain inoculum of mould or virus or bacterium and who isn't. You can't say. It's best just to minimise it all, in conjunction with all the other things like surface cleaning and hygiene and stuff like this. But it's best to remove it all and buffer everyone.
The service you're setting up, is that something you're doing on your own at Addenbrookes?
I'm doing that at the moment as a part of my collaboration with the university and as an NHS employee, because in the hospital we have at-risk groups and at-risk wards, and here's a simple and effective in-house grown methodology to see whether the air is clean or not. And so I'm driving in for patient benefit in our hospital, but it's hand-to-hand with the Baker Lab, and that's what we're doing at the moment. But it's not scalable or at a big scale. It's for our hospital and for our wards at the moment.
If you had a magic wand, what would you like to see? And if that happened, what potentially could be the impact?
If I had a magic wand, I'd want lots of things. And I would like to be able to, in those areas where there are high vulnerabilities of patients, care homes, hospital areas, schools for vulnerable children, in those areas where there's high risk of airborne transmission of disease, I would like to be able to define, or I'd like to prove that the air is clean, number one. Number two, store that data such that I would know what the microbiome, or in other words, what is the pattern of pathogens in that particular environment. See how that changes over time and with other influences. For example, antibiotic stewardship is a big thing for us medics. It's our climate change. And if we had a decrease in acquisition of airborne transmission of disease or pneumonia, then it would be interesting to see whether we scaled up the antibiotic treatment of pneumonia, or to more broader and broader and more dangerous antibiotics, or whether we retained our ability to use specific antibiotics, which is much safer. And to store that data in the cloud or wherever like this, and to compare and contrast different environments that we think are similar, and to tease out what they're doing differently or what is different, and what are the confounding factors, would, I think, contribute to an understanding of disease acquisition and promote better antibiotic stewardship. That's what I would like to do, in conjunction with other things like precision diagnostics, which is coming. Molecular diagnostics is on the future. So you reduce the amount of infections that they're getting, and the ones that the patients are getting, you get precision diagnostics for what antibiotics or antifungals to use. The two, hand in hand, would promote much better antibiotic stewardship.
Do you think there's opportunity to have a national air standard?
I'm not. It's a really difficult question to answer, because we don't know what you mean, what is meant by a standard, because the risk varies. You could have a standard, but some people could be at risk from that standard. So I can't see how that's necessarily going to work. Although we have standards for food and standard, I don't quite know enough about them or how they're implemented or the way they're measured. But what I can see is that people making a sensible attempt to mitigate risk, just as you do with hand washing and surface cleaning, mitigate the risk of airborne transmission of disease, and knowing that they're doing it. And because if you have a low level, or as low as you can achieve, you've done your job. You can't stop all infections, you won't, it's not possible. So people won't meet the standards because they'll get a hit at a low standard or a high standard.
How many air changes is a sensible number of air changes in a room?
We did 5 to 10 room volume filtrations per hour in our study, and that was effective. In some other work that we've done just now, which is not published yet, but we've shown that actually in operating theatres the environment is very good in 20 room volume filtrations per hour. And it would be interesting to plot a dose-response curve. In other words, what's the intervention and what's its effect? As we do for all sorts of things that we do in medicine, whether it be drugs, whether it be interventions or anything like that, plot a dose-response curve to find out what's the optimum level of intervention and what's the optimum response. But I suspect that the responses will be different according to where you are. And if we were to err on the side of safety, then it seems to me having more than 15 room volume filtrations per hour might reach the peak of the curve on the plateau area. But although that would vary with seasons and vary with people and vary with disease burden, I guess, which means that you'd have to measure more often.
Do the levels of the amount of occupants in a room really matter that much?
I would think so, but it depends the occupants in what room. If it's an occupants of healthy people in the cinema, then probably not. But 10 people with chronic obstructive pulmonary disease who are bronchiectatic, and within that room, I suspect it's the occupancy and the duration of occupancy and who's in there. If they're all in there for a long time, and you're not making an attempt to remove the pathogens in the air, you'll get airborne transmission. Whether it becomes clinical or subclinical, whether they develop a new infection or not, I don't know. But the principle of occupancy and disease transmission is well known. It's definite. It does exist.
During your study, you put units in an ICU ward. Would you widen that if you could?
With COVID, when you're on ICU with COVID, you have a different disease to the one that when you're on the ward with it. If you're on the ward with it, you have an upper airway disease and it hasn't reached the depths of the lung and you've not become critically ill. If you're on ICU, you're with me and you're on a ventilator and it's a much deeper, more infection, and you're on closed circuits. So there isn't much dispersal of that. However, we found that there were other pathogens in the air on the ICU when we removed them with the air filtration units. On the wards, where people are not on ventilators, they are awake, sitting up with oxygen masks on, breathing, talking, coughing, there's much greater dispersal. If I were forced to have a choice, I'd choose the ward because there is a greater burden of risk of deterioration there. Whereas on ICU, if we're just talking about COVID, then they're already tumbled and with us already. But for other pathogens, the ICU is also important because these patients are really sick and if they don't come off the breathing machines, if they don't get better soon, they'll get sicker, and that's usually from infection. So things in the air that coalesce and land on drips and tubes, put them at risk. So I'd rather not be forced.
Do you believe in the future we'll have similar systems for air treatment as we do for something like water treatment?
I would like to think that adding air filtration units to risk mitigation in areas of high vulnerability would be a sensible way to take the next step. To prove whether they decrease infection rate or not, it's going to be a very difficult task because there are so many confounding factors between one human being and another as to whether they'll get infection or not. So I would like to think that it would be a contribution that should be made to add to current strategies for infection prevention. And it's relatively easy to do.